Good evening, everyone. Thank you very much for joining us for the HEALTHSPAN Lab. My name is Madina Estephan, and we are going to discuss today shifting the paradigm of patients with chronic diseases. So I'm happy to welcome my guest, Dr. Salem Salem, who is a friend of mine, but as well as very experienced endocrinologist, nutritionist. Salem, good evening, and thank you very much, first of all, for accepting my invitation and joining us for the live talk to share your experience around the care of the patient with chronic diseases. The floor is yours.
Thank you, Madina. Thank you for inviting me. I am very glad to be here to talk with you about this interesting topic. Yes, I will introduce very quickly myself. So I'm an endocrinologist. I studied before internal medicine and endocrinology in Brussels. I started my professional life in university hospitals. And after some years of experience in teaching as a chief of clinic, I had a choice to do, and I chose to work in clinical practice. So I am mainly now a clinical practitioner in endocrinology and diabetology.
As we know, during this unprecedented crisis, we had quite an unusual situation. According to the recent study, half of the general practitioners and 1/3 of the secondary care practitioners closed their offices for the traditional face-to-face visits. So, and with emergence of new type of consultations, with emergence of telemedicine and e-health regulatory paths, my first question was how the current crisis impacted your vision of patients' care, and especially the patients with chronic diseases.
Yes, first, I realized the fragility of our medical health care system. Our French medical system and even most developed countries' healthcare system are not ready to face such a sudden crisis. The routine medical practice used to respond to medical needs on peacetime when requirements are minimal, but not during such an epidemic. The COVID-19 crisis constitutes a big challenge, and this constitutes as a stress test to our system. And unfortunately, our system has failed the test. At the beginning of the epidemic, we used the middle-age method of confinement because of lack of masks, lack of tests, and lack of intensive care beds. Nobody before that could imagine how we are disarmed facing just an upper respiratory tract infection. My first impression about the changing of this medical system approach during this crisis.
Thank you, Salem. And I hear it, and I heard a lot of, I had a lot of feedbacks from my colleagues as well, who mentioned that we never faced such a situation before. Can you give us an idea about how the crisis impacted doctor-patient relationship and what are the consequences?
Yes, the relationship patient-doctor has really changed. It improved no matter the masks, no matter the distancing barrier. Medical doctors showed to be courageous and sometimes heroes. On the other hand, they appear to be fragile, and this reinforced their human face. Patients unconsciously think their doctor invincible, to my point of view, dealing successfully with diseases, and is able to dominate illnesses. Patient think that his doctor is qualified and is the fittest to survive on epidemics. But the reality showed that medical workers are the first to fall on the battlefield, facing just a COVID. The fragile human condition made the relationship patient to doctor more balanced, and this made that relationship warmer, some kind of soldiers' solidarity on the front.
And what about the, you know, the empathy and compassion should be the factors that doctor-patient experience both, and knowing how you treat your patient and knowing how compassionate and empathic you are during the consultation. Do you feel that these skills were even more important in this terrible and hard time for them?
Sure, because when you deal with chronic disease, as you know, Dr. Estephan, a strong ties could be installed between you and your patient on a long-term construction process. During this crisis, discussions during the consultation concerned not only the strict medical questions, but also daily life concerns and security topic concerning the family problem. And this created a more friendly approach, a warmer approach. Most patients ask their doctor about the reason of difficulties and how all this will end. In my experience, the fact that I was sick on COVID was considered as a kind of medal by my patient. Some of them criticized their family doctor to have disappeared since the epidemic, started considering him as not present when needed. This do not concern ill doctors, who was very well seen by their patient.
I hear it. Thank you very much for sharing this hard experience for you. You know, Salem, we're talking a lot about the difficult time for our healthcare professionals, and especially for their mental health and the presence of tremendous stress factors during this unprecedented situation. What type of techniques do you use, for example, or what kind of situation can help you to support this stress in the different way and find the internal resources?
Yes. These are difficult times for medical doctors, and I think that we had to be transparent. Transparency was important, and we shouldn't try to play the role of heroes. And when we don't know, we don't know. And during the crisis, many doubts emerged. We had to prove to ourselves sometimes that you are strong. But an unconscious titanium doctor is not a good doctor. We should think also, before taking risks, about our families. Yes. For some of us, the fear of the disease could have affected the self-esteem, I think.
Yes. Yes.
Yes, and the gratefulness of the population is very reconforting. In fact, I don't see heroism in what medical doctor did, and the opposition could be an anomaly. It could be something abnormal. The fact that they went to job and they took risk, it was the time to do that. It was for them to do that, and it's normal thing. But it was a really difficult period, and we will remember that for a long time.
What kind of new barriers do you experience during this time?
Yes, first of all, we had this physical barrier. Masks is a barrier. Sometimes you cannot recognize your own patient, and it's something that make you a little bit unstable about that. Who is that patient? But I know his voice, but I don't know his. I cannot recognize his face. for many time, I asked them to show me their face, respecting the distancing. Another barrier is also the distance that we had to keep. And some patients preferred to stay without sitting, yes, up, standing up, because they were afraid to touch the chairs. Some of them wanted a very short consultation. They expressed their fear of being contaminated. And I tried to explain to them that once the rules are respected, yes, no places for paranoia. Yes. But we still had an eye-to-eye consultation and face-to-face, and this was something I think comfortable even for patients.
Do you think that the fact that the ritual changed? I understand they have their beliefs, and of course scared to be contaminated during the medical visits. That's probably impacted the fact that many of them prefer to wait and to come later. But on the other side, do you think that the absence of rituals was somehow replaced by other things, accompanying the patient in a different way? How do you?
Yes, I got the point.
Yeah.
Sure, the ritual are important in concept, even in consultation, and the consultation lost some of its important major points in ritual, but also in physical examination, which are reduced to the minimum because we just wanted to. At first, we were not very careful about the security rules. Then after, we became very careful, and we diminished the physical contact to a great maximum. Even though this physical or face-to-face consultation, even though it resembles to a teleconsultation, but still something more about that. This vibration, vibrating contact, gives something more, in my point of view.
So, do you mean that the COVID crisis impacted your therapeutic alliance with patients?
Yes, sure. It's invited most of us to introspection, and some patients seems to be more interesting in controlling the risk factor than before the crisis, because they heard that diabetes is the greatest factor. For example, many diabetics showed more motivation toward a better equilibrium of their diabetes.
So
for that reason,
that was the positive shift in the patient behaviors.
Yes, the media played a role while talking repeatedly about the vulnerability of diabetic patients facing COVID infection, and the unavailability of medical doctors during the crisis. This reinforced the alliance with those doctors who are available. So the patient showed compassion and more trust, seems to me.
Appreciation that the physicians were able, I know some of my friends were doing even the home consultations for the elderly patients who couldn't come to the clinics. And I know that you didn't close your office, and it was open once you have the ability to continue. How about the place of humor in your patient's management?
I realized that long time ago that some humor has a large place in making the consultation less dramatic. Yes. I believe that humor increases the patient receptivity. So, during the epidemic, some humor concerns the disguisement with the mask, and sometimes the benefit theoretical benefit of mask on masking hirsutism, for example, and so on. Well, and I remember Woody Allen saying that we should never be too serious, since it will be no survivors.
What's the common features between the teleconsultation and in presence or face-to-face consultation? So,
yes,
except the barriers, there are barriers, right? And we're
yes,
going to have them for a while.
yes, the common feature is during the crisis is that, as I just told you just before, that we minimized the physical consultation during the epidemic. But this is only during the epidemic. If we compare physical consultation, face-to-face consultation, and teleconsultation, far away from the crisis condition, yes, I think that physical consultation can have much more positive point. But during this crisis, still the voice, the capacity of this plus of vibrating, I can say it, as when you assist to a concert. It's not the same as listening to a CD. No, why to go for thousands of kilometers to see his mother, for example? If you have Skype, but you may do that. You know, for the same reasons, I think there is a big plus in face-to-face consultation, even though with this barrier and with during this minimizing condition. I think that also we prefer to meet her or his lover face-to-face than call him. No?
But at the same time, we have the results of the very big company in France who has the major part in teleconsultation, that these 2 months they have increased it up to 650,000 of new consultations. So definitely that will be the part of the patient care management today. And the one thing, especially I'm thinking about this possibility to respond to the needs of the geographically poor places for the medical care. And
yes, this medical desert.
Yeah,
yes.
The deserts, yes, we have them. So somewhere it will be the way to reply to these needs.
For sure, I'm not denying, yes, the benefit of teleconsultation, but there's concurrency, and there is also they are complementary even.
Yeah, right. The right mix, you mean? To have
yes,
the right mix. You know your patients for many years. Some of them perhaps are coming to see you also, as you said, as a member of the family now, because they need also different advice, not only on the treatment, but in the general way, on their life behavior sometimes, right?
Yes, sure. So their behavior changed. Some of them, as I told you, were in a hurry. They didn't want to touch anything, and they wanted to shorten the consultation. Others sent either their son or their daughter to represent them on the consultation. Others also, they have a very friendly attitude, more friendly, towards their doctors, and compassion. Yes, we felt that, and especially when they know from secretary or from other patient, or that their doctor was sick, and especially in this COVID. So the doctor had some kind of certificate of devotion as a medal. Yeah. And so patient was grateful. And it was this interesting, this reaction about that.
Salem, do you think that we had tremendous amount of patients who waited and were scared and didn't come.
Yes.
Did you notice that your schedule was sometimes canceled, or they prefer to wait till the crisis will end?
Yes, sure. A lot of them waited, and I'm seeing now, since crisis is recovering, and that many patients are severe, presenting acute illnesses. For example, I'm seeing pregnant women with very unstable diabetes or with hyperthyroidism. I'm seeing also many diabetic foot problem that should be taken in charge much before. Some cardiac arrhythmia with hyperthyroidism, and I waited a lot. And I experienced two cases of myocardial infarction with patients who preferred to stay at home, and one of them needed a cardiac transplantation. And
he waited, but he had it finally, right?
Yes, he had his cardiac transplantation. Yes, so there is a lot of collateral damage of COVID epidemic. Those patients who also delayed their prevention test or exam or consultation, even for cancer screening and so on.
Do you think that current situation with much more patients hospitalized with complications will continue for a while, or we will be able to manage this quite quickly?
I think we'll be able to manage that quite quickly, because during the peak of the epidemic, we reduced the medical care to the minimum, only to the acute situation. But since COVID is diminishing a lot, so I think that we will have the possibility to take in charge progressively this patient, I think, hopefully.
Okay, and what do you think, from your professional opinion, what will be the new requirement for patients' care to be put in place after the COVID crisis?
Some patients will be demanding a teleconsultation for time consuming or due to lack of motivation. They did experience that. This is more used now. Most of them, I think, will seek a direct contact with their doctors. I believe that. Also, a further evaluation is needed to assess the long-term efficiency of teleconsultation on chronic disease and the final outcome, comparing to traditional consultation. Maybe it's as good as traditional. To my point of view, it's a complementary. I prefer by far the traditional consultation.
To have them face to face, I understand. Yeah.
Yes. I have the feeling on teleconsultations that we are just doing the minimum needed. Yes. In some cases, there's no other way to do that. And I think that, as we said before, these two
Salem,
tools will be
except
complementary.
the changes in the patient care management, how did the crisis impacted your organization process in the clinic? Is it considerable?
Yes, everything was changed. So as I told before about the priority of acute things, all prevention measure or even surgery, not urgent surgery, has been delayed, and the hygiene measure, distanciation, also was very ignored at the beginning and very tough at the end. One outpatient where I used to work has closed for 1 month. Then after, because all secretary uh, has,
was low.
contracted COVID, and a lot of medical doctors. Then after they opened it with a very tough hygiene requirement, and now it's okay. Yes.
Do you mean it was a kind of investment to be done also for some clinics and centers?
Yes, nobody was ready, and how to find the professionals who are able to put plexiglass protection, for example, and to have enough also, how to say, a steward or security guy who should how to say, organize the entering and the one way circulation, and so it took, and there nobody had an experience, a practical experience to start it in an emergency way. It took time, unfortunately.
Do you think that we will finally realize that we need to do something more than to treat? I mean, how about the preventive measures and preventive medicine? What's your opinion on that?
Yes, preventive medicine is the gold standard. It's the most important things. And in diabetology, which is my specialty, patients have integrated the idea that it's very important to have a good diabetes to prevent complications, and so I am seeing also new patients with very bad diabetes, and motivated by this idea. So, and in prevention medicine, also teleconsultation could have an important role, but myself, I don't know yet. It needs to be confirmed by studies, evaluating studies, but maybe prevention consultation even is better on face-to-face, because the patients are not very motivated for prevention. When they are sick, when they have a pain, they are motivated. But for prevention, motivation is much less. So we are more convincing when we have the patient in face of us. But for also patients are not the same. And for some patients, teleconsultation could be a good solution for in the preventive medicine.
But don't you think also in preventive medicines there is a place for all new type of devices which we have now, applications and connected objects and educational, which can do the educational part, for example, or help to put some changes of life behaviors?
I agree with you, Dr. Estephan, on that. But it touches maybe young or not very old patients. It depends. It cannot touch all patients, but it touches a great part of those people who are well connected. But sure, there is many modern tools, efficient, yes, and
which can help too. Yeah, especially I was thinking about the obese and diabetic younger generation, where they're more digitally oriented and maybe more easy adopters of these practices.
Yes, sure.
And, yeah. Okay. So and how about the, we have in Sensemakers one position that except the medical practice, right skills and professionalism, physicians perhaps are the most well-placed specialists who should think about having practical wisdom. Do you think that during this uncertain and unpredictable crisis, did physicians acquire the practical wisdom skills?
Yes, I am sure about that, because medicine, as one of my professors in Belgium, in Brussels, used to say, that medicine is the art of managing in uncertainty.
Yes, that's clear.
And during this crisis, we had to adjust everyday practice according to new studies, sometimes to new controversies. And it was something very unusual to not to have guidelines, to have almost nothing, and nobody was okay for a treatment. Nothing was, no consensus on treatment. Excuse my bad English. And so we needed some kind of common sense, not to take risk, to evaluate the benefits risk of every therapeutic decision. And this was something new, to navigate without GPS on that therapeutic decisions, for and not to take risks for patients. A good solidarity between different corps of the medical health system, and we realized that, and the reserves was deployed, and it was a good, very, very good surprise, especially in intensive care, where they increased their capacity more than double in a very short time. And what this needed a lot of training, a lot of material involvement, and was a success. In fact, in our crisis management, this was the real success, because we lacked materials test, as you know from the beginning. But the intensive care succeeded. This last barrier before death, in some cases, could how to say, succeed in receiving all reanimation patients. In France, the reanimation patient was taken in charge very, very carefully and successfully for most of them.
So hopefully that will be something which helps us in the future anticipate better the crisis situation, and to manage them even more successfully than now. Which paradigm, from your point of view, shifted during this crisis, and we observed it?
Yes. At short-term action, we left prevention, and we dealt almost only with acute situations. But at the long term, I think that telemedicine, it showed new interesting features, and it will certainly be more used in the future. Yes. Nevertheless, it's still an adjuvant tool to traditional face-to-face management, which is, to my point of view, the gold standard of medicine. So the new paradigm is, if I do a small summary, in crisis, we deal only with acute situation, and we leave everything for later. And this acute situations improved medicine. I think this stress test was difficult to our system, but it improved it. Mainly in reanimation, they improved a lot their techniques, and also we improved our comprehension about telemedicine, and it was more diffused. And this would be an interesting feature, especially for medical deserts.
I understand. Thank you. Thank you very much, Salem, for this discussion. And I will just make one comment, that we are definitely in the era of acquiring new technologies and implementing the new technologies in the
in the 19th century. It was the industrial revolution. And
yes, right.
in the 20th century, in the end, it was the digital revolution. And we still waiting more involvement of this digital revolution in medicine. For example, as to have this digital insulin pump completely automatic, and still other applications. And we may have also in this 21st century the genetic revolution coming, which is somehow also related to program coding, genetical one this time. It's not so far from the digital revolution. And I believe that we may find a definitive result or treatment for many chronic disease. And the digital tools could help, but our ambition should be to treat definitively, to recover this patient. And it's not impossible. I'm even confident. I'm not sure to say it myself, but I'm confident that humanity will resolve that.
Yes, so we're
I
all
agree with
for
you.
the new emergence of the new treatment. Thank you very much for once again for your time.
It was a pleasure. Thank you for inviting me.
Thank you, Salem.
It was a real pleasure.
Have a nice evening. Bye-bye.
Thank you. Bye-bye.